My name is Peter Hojebeck. I am CEO of Avidicare, and we are the sponsor of this event. Today we have attendees mostly from the US, but I can see on the list here that we have a couple also from Europe. Today's topic is about improving the comfort and the safety of surgical personnel with temperature-controlled airflow. It's part of a series of webinars that we are doing to share knowledge and also to share awareness of airborne contaminants in healthcare. And I know that many of you already know about Avidicare and our mission to reduce the risks from airborne contaminants. That is mostly, of course, bacteria and viruses in healthcare. Our company started more than 10 years ago, and the rationale why we started was, of course, we do not think it's acceptable that so many people die in hospital-acquired infections. Actually, a lot more than die in traffic die from these infections, and we think we can do much better. And now also following the pandemic, we believe that we can do more to help healthcare remain resilient against these kind of airborne threats. So with this background is why we have invented temperature-controlled airflow as a way to do better. Our first clinical installation is since 2007, and we have been working really hard together with leading experts, both in academia and in industry, to validate the solutions and its abilities. So that's what this webinar is about. It's about sharing those experiences from the experts, from those who have studied temperature-controlled airflow, and let them share what they see and let them tell the story of how it works. So that's why today is a great privilege for me to introduce our two speakers. First today, I will introduce both of them today, and then we'll have them in turn. First, it is Kathy Wary. She is CEO at Infection Prevention Partners. She is, I think, known to many of us already, since she served as CEO of APIC, the Association of Professionals in Infection Control and Epidemiology. There's no E, but it's APIC. And she did that for several years. She's also been the global director for infection prevention at BD before starting her own firm, where she now works as an independent consultant. The second speaker of today that will follow and do the second part of this webinar is Professor Clemens Bulita. He brings a unique combination to this session because he has a very rare combination. He started his training as a surgeon and working as a surgeon for about 10 years' time, including serving some time and doing some work as a postdoc at Harvard. He then spent 10 years in industry in Siemens Healthineers in various management positions. And now, since I think 2012, he's been a professor at the German University of Applied Sciences in Weiden, where he both founded and now is running the Institute of Medical Engineering. So with this three dimensions in his experience, I think we'll have some really good insights from him as well. Today's webinar will be about 40 minutes presentation from Kathy first, and then from Professor Bulita, and then we'll have about 10-15 minutes of questions and answers. If you already have a question now or during the webinar, just type it into the chat, and we'll keep it there, and we'll make sure to bring it up during the questions and answers session. That's about it from me. So now, please, Kathy, the web is yours.
Well, good afternoon and welcome to the webinar this afternoon. It's a pleasure to have this opportunity. As Peter mentioned, I have spent the better part of the last 20 years in infection prevention. And over that period of time, I have witnessed tremendous innovation. When you think back to the year 2000, we had hand hygiene and gowns and gloves and some environmental disinfection products, and that was pretty much about it. But the estimate for the size of the infection prevention marketplace in just the US alone by 2025 is it will be upwards of $250 billion. That represents tremendous innovation. However, I have not seen any innovation in a very important technology, and that's operating room ventilation. I consider ventilation to be an infection prevention technology because one of the primary functions is to protect operating room personnel and patients from the risk of airborne contamination. And the technologies we're using today in the operating room really date back to the late 1960s and the early 1970s. And this may be why we're struggling to get further reduction in surgical site infections. But with the introduction of new technology into this space, I think we have the opportunity to not only improve the safety of healthcare workers and patients, but also the comfort of operating room personnel. So I wanted to disclose that the development and delivery of this presentation was supported by an unconditional educational grant from Avidicare. We are offering 1.2, or this program has been approved for 1.2 continuing education units for nurses. I'll give you a bit more information on that towards the end of the presentation. But at the end of this presentation, you should be able to review the role of operating room ventilation in providing for the comfort and safety of surgical personnel, explain the limitations of current approaches to operating room ventilation, and discuss temperature-controlled airflow technology as an alternative to conventional ventilation systems. So as far as today's program is concerned, we will move through airborne hazards in the operating room, factors affecting comfort of operating room personnel, different operating room ventilation systems on the market today, the science behind temperature-controlled airflow technology, and end with a comparison of ventilation systems, including their impact on comfort and safety. So we know that gases and disinfectants are an airborne hazard in the operating room. Exposure to anesthetic waste and other gases can cause nausea, dizziness, headaches, fatigue, and irritability, as well as much more serious effects such as sterility, miscarriages, birth defects, cancer, liver and kidney disease. And while chemical disinfectants are less of a risk, their inhalation can result in irritation of the eyes, nose, and throat. Surgical smoke is a particular concern. We all know that AORN in particular has been advocating for the use of surgical smoke evacuators for quite some time now. Surgical smoke is a hazard that can cause ocular and upper respiratory tract irritation and visual problems at a minimum. But it has also been shown to contain viable bacteria and viruses. Staph, human papillomavirus, HIV, and hepatitis B have all been isolated from surgical smoke, as well as the bacteria that causes meningitis and diphtheria. Carcinogenic and mutagenic particles have also been isolated from surgical smoke, as well as viable malignant cells. And adverse health outcomes that have been reported include human papillomavirus infection. HPV in particular has been epidemiologically linked to disease transmission, as well as cancer and bacterial infection. We know that smoke removal is inconsistent. There are a number of barriers to its use, including noise, cost, resistance on the part of surgeons, staff complacency, and just the sheer size of these devices. A survey from NIOSH found that evacuators are used in only 14% of electrosurgeries and 47% of laser surgeries. And the graph on the bottom is a survey that was conducted by Stryker in 2018, evaluating or surveying nurses and operating room directors and leaders on their thoughts with regard to barriers to the use of surgical smoke evacuators. And while there may be some disagreement there in the results about, what are the primary barriers, it's clear that the barriers are many to surgical smoke evacuation. And so I think that when surgical smoke evacuation is inconsistent, then this just highlights the importance of having adequate or highly effective ventilation in the operating room in terms of evacuation of airborne contaminants. So COVID-19 obviously has been a great concern, but other respiratory viral aerosols pose a risk to operating room personnel. And this is true in particular with orthopedic surgery, it presents specific challenges and difficulties because power tools, hammers, and other instruments can spread airborne particles. And aerosols have been shown to spread from 5 to 9 meters during orthopedic surgery. That's over 16 feet. And the surgical personnel, personnel performing aerosol generating procedures, we know are at high risk, and that positive pressure ventilation can spread bioaerosols. So early in the outbreak, Alistair Hart, who chairs the Department of Orthopedics at the University College of London, made a statement with regard to COVID-19. He said the combination of power tools, high velocity blood splatter, and ventilation systems can produce a viral wind tunnel. If the theater has had anyone with the virus in it in the previous 72 hours, the airborne aerosol could have landed on some surface, including the ceiling. Protecting against that, even with stringent cleaning, is almost impossible. Very soon, all of our operating theaters will be covered in COVID-19. And then you switch on the ventilation and you blow it all over the place. Now, I know that COVID-19 as a risk to operating room personnel has significantly lessened now that the standard of practice is to test patients in their pre-surgical workups for COVID-19. However, I think this statement holds true with regard to airborne bacteria in the operating room in general, regardless of the virus or organisms that might be present. The conventional ventilation can blow that contamination throughout the operating room. We also know that COVID-19 has resulted in the death of healthcare workers globally and in the US. At the beginning of the epidemic, Johns Hopkins did a study to estimate the infection and death rates among US hospital workers. And this was based on 100 COVID-19 related deaths in the general population. So the number of healthcare worker deaths based on per 100 COVID-19 deaths in the general population based on what had been observed in Hubei, China, and Italy. And they estimated that 53,000 hospital workers in the US could be infected, and that approximately 1,600 could die due to COVID-19. They also, this was early in the pandemic, and they made the note that making PPE available to all hospital workers and reducing the exposure of those above 60 would significantly mitigate these risks. We know that PPE, the shortages have for the most part been alleviated, but that implementation of these strategies will have challenges. We know that lack of PPE availability could be an issue moving forward, and certainly the increased cost is an issue. They concluded with a statement that it is entirely possible that this is an underestimate because the number of hospitalizations in the US has far exceeded their original estimate. And they concluded with the statement that healthcare workers remain worried about their health and the health and safety of their families. So at this point, we would like to conduct a survey of those of you participating and to ask you to what degree you're concerned about airborne contamination in your operating rooms and your level of risk. And at this point, I'm going to turn it over to Avidicare. There we go. And you should see buttons there that you can respond. Okay, so the highest response is slight concern. 43% of you indicated you had a slight concern. 14% of you said you didn't have any concern at all. And 29% indicated that you were very concerned. So doing some quick math here, it looks like it's about a 50-50 toss-up between minimal concern and a fairly significant level of concern. So I would say that, you know, it's also epidemiologically difficult to link occupational exposure to disease, and that perhaps airborne contamination could be an underappreciated risk. But I think these findings are quite interesting. There we go. Okay. So moving on, we also know that noise is an occupational and patient safety hazard, that the health effects of noise can include tachycardia, fatigue, illness and injury, irritability, anxiety, emotional exhaustion, job dissatisfaction, stress, and burnout. And that noise is linked to poor concentration and inability to perform complex problem-solving tasks. A number of organizations, the Environmental Protection agency, OSHA and the WHO, have all indicated that continuous background noise levels in hospitals should be limited, suggesting that they not exceed 45 decibels. We know that the average ambient noise in an operating room is about 65 decibels, but the peak levels in trauma and orthopedic surgery can reach 120 decibels. And it's at 70 to 80 decibels that hearing loss becomes an issue. And in reviewing the literature on this, it looks like there's increasing concern around hearing loss on the part of orthopedic surgical personnel. Most of the studies in healthcare on the impact of noise have been conducted with anesthesiology providers, most likely because they have complex work streams and that they have to maintain cognitive awareness of multiple work streams. One study that simulated background noise of an average operating room with residents, anesthesiology residents, found that there was a 17% reduction in the accuracy of their detection of changes on a pulse oximeter. And then the study that's in the graph on the right side of the screen was conducted by the Mayo Clinic. And this was part of a performance improvement initiative to reduce noise in the operating room. And their survey of anesthesiology providers looked at perceived cognitive processes and performance. And respondents said that 45% found that their performance was negatively impacted by noise during their observed case. 75% noted a decreased quality of care, and of those, 40% said that noise had led to an adverse or near-miss event at some point in their practice. Efforts to limit noise in the operating room are also many. ARN recommends limiting sources of noise that are not essential to patient care, and the Joint Commission recommends equipment alternatives that produce less noise. And NIOSH has actually a buy quiet strategy where they recommend that health systems investigate models of powered surgical tools, blades, and other equipment that produce less noise, and suggest transitioning to tools and equipment that generate the least amount of noise. So ventilation as a source of noise disturbance has not been widely studied. The evidence is limited, but there are a couple of studies that segmented out ventilation as a source of noise disturbance for surgical personnel. And in this study, investigators found that background noise created by high-speed ventilation can be a source of discomfort and distraction. Their survey of 684 operating room personnel found that 30% of the nurses, 16% of the surgeons, and 26% of the anesthetists considered ventilation to be a source of noise disturbance. And you can see on the right that they looked at main sources of noise, including machines and air conditioning and ventilation systems. Thermal comfort can also impact operating room personnel. Negative impacts of temperature, humidity, clothing, air quality, and ventilation has been shown to lead to thermal discomfort, perceptions of reduced work performance, health problems, stress, and tension. And ventilation, once again, can be a source of thermal discomfort and distraction for operating room personnel. In this study of 68 surgical personnel, investigators found that 40% of them were affected by the ventilation. And of that group, 82% said that the thermal conditions were not within their comfort range, and that the perceived effects of thermal discomfort ranged from reduced work performance to health problems to stress and tension. So we'd like to conduct another survey with you and ask you how the ventilation system affects you in terms of temperature and noise. Whether it's positive, negative, or neither. And then the extent to which you feel negative, if you are negatively affected, how much would you estimate that to be? So once again, we have our poll up and would ask you to vote your choices. 43% of you said that ventilation negatively affects you. 57% were neutral, saying that it neither positive nor negative impact. And then of those of you who felt that it negatively affected you, 43% of you said it was slight. 29% of you said that it affected you to a moderate degree, and 14% of you said that it affected you to a high degree. So I think it's very clear that ventilation does have effects on operating room personnel to varying degrees. I just wanted to make sure that I'm at the end here. Yes, and at this point, I would like to turn the presentation over to Dr. Belita, who is going to take you through the science behind temperature-controlled airflow. And we'll turn over the screen to him.
Yeah, thank you very much, Kathy and Peter. So I would like to tell you a little bit more about our research experience with the temperature-controlled airflow. As you can see perhaps on my virtual background, this is our research OR. We are doing research on a temperature-controlled airflow now for about 5 to 6 years. And I would like to tell you a little bit about our research experiences, but also about the basic principles and concepts behind this technology. And let's start with the reasons basically why a temperature-controlled airflow was designed. Mainly, and this has been covered by Kathy pretty much, there's 3 main objectives for ventilation systems in operating rooms. One, of course, is occupational safety, and Kathy has elaborated on that already. The second one is, maintaining a proper atmosphere, removing thermal loads, managing temperature in the OR, and of course, the third objective is infection control, infection prevention, and therefore, of course, that was one of the main objectives behind the temperature-controlled airflow technology to really achieve ultra-clean air conditions within the entire operating room. And I'll come back to this a little later, what is behind this entire. Then, of course, improve the comfort for surgical teams and the safety for the teams as well as for the patients, of course, and optimizing energy use and making it efficient. We have a lot of installations in Europe, and actually it's kind of interesting if you look back about 20, 30 years. That was when I was still in clinical training. Most of these aspects of OR ventilation weren't really a big topic of discussion. It came up, let's say, overall for within the past 15 years, even though OR ventilation as an issue has been studied in the 60s already. And it was found at that time, that minimizing the airborne contamination in operating rooms could significantly, and this was mainly in the era before perioperative antibiotic prophylaxis, that reducing airborne microbial load significantly reduced total joint infections after total hip and total knee replacements. So I think it is an important issue now, and even in Europe, it's been a discussion what the best way is, and I guess this was one of the main reasons why this technology has been developed and is gaining more and more ground. So we have around about 250 installations in Europe to date, and with research that has been done, there was a lot of measurements also during live surgery, and I will share some of these results with you. And to actually summarize it, the temperature-controlled airflow meets all the national requirements in the US, but also, of course, for many of the European standards. How does it actually work? Mainly, if you go to the figure that is displayed here on this slide, you can see that you basically have some kind of a plenum in the middle where HEPA filtered air is dispersed from these air showers that you can also see on my virtual screen, with an air temperature that is about 1.5 Kelvin cooler than the ambient room temperature at the height of the OR table. This creates a gravity-driven downflow, consistent, and actually creates a, if you want, a protected area and a almost unidirectional flow in the center area. And then you have the combination with the external air showers in the periphery to really control the overall air movements in the room and to make sure that air is mentioned as a risk factor for infection within the entire operating room, not only in this center part where the OR table is. And why this is important, I will tell you in a second. So this temperature difference creates a speed of the air falling down of slightly more than 0.25 meters per second, which is exactly what you need to break body convection that heats up also the convection from equipment, etc. And the overall management of the air and the outlets prevents also stagnation zones. And what is most important, you know, this principle works basically at any temperature. So you can actually adjust room temperature and humidity to any level, which is an important issue, as we all know that normothermia is one of also the critical aspects in preventing surgical site infections. Moreover, you know, as this is a rather new technology, of course, we wanted to know how is this actually performing in comparison to established ventilation technologies like laminar airflow or turbulent mixing ventilation. And a Swedish study looked, and these were all operating theaters in the same hospital, in the same enterprise. So it was the same staff basically operating in different operating theaters. And, you know, they had basically the same configuration except for the ventilation system, these operating theaters. And with regards to the aspects that Kathy was referring to in this study, the team looked at the impact of the ventilation systems on the working environment and was surveying 82 people of the orthopedic surgical staff there, and it was about equally dispersed through the different ventilation systems, so almost equal amounts of responses of the survey from the different setups. And the questions we're asking for the experience with drought and how it actually affects the staff. So it was, assessing really the subjective experience. It was also looking at the perception of noise and to what degree it was affecting the staff and how the overall comfort was perceived. And if you just look at basically two aspects. So we have here the laminar airflow, the turbulent mixing ventilation, and temperature-controlled airflow. And we can see here with regards to the comfort level that the negative, there was a clear negative impact by the laminar airflow system and a clear positive impact with the temperature-controlled airflow. It was more or less neutral with the turbulent mixing ventilation. Definitely from the perspective of the staff with regard to the comfort, there was a significant positive impact by temperature-controlled airflow. When asked the degree to which the system affected them on a 7-point scale, the median was about 5. So as you can see, that the laminar airflow really affects the staff negatively in a significant manner. if you look at the questions 1 and 3, it was clear to see that here we also have the 3 different systems: laminar airflow on the very left-hand side, turbine mixing ventilation in the middle, and temperature-controlled airflow on the right hand. The noise, even more the noise than the drought, was a significant issue with laminar airflow. And there is studies also by other groups that came to similar results with regards to the thermal comfort during surgical operations with the established ventilation systems. So the question now is how actually can temperature-controlled airflow improve this aspect of thermal comfort? As I mentioned already, temperature and humidity can be set at any level to ensure safety and comfort of patients and staff. So you could actually really manage the different zones. So you could keep it cooler in the center where the staff is very active. You could keep it warmer in the periphery. And especially when it comes to patient safety, you can even, heat up the room for, let's say, burn patients or neonatal surgery, and maintain a very warm environment without compromising the downflow function, and therefore the management of the airborne microbial contamination. How does it actually reduce noise? The high air speeds that usually comes with and the high air volumes that usually come with laminar airflow systems and many of the turbine and mixing ventilation systems is not necessary when you operate with gravity. So the overall speed of the air is lower and has a lower impulse, of course. And this is one aspect. Moreover, there's a smaller footprint, which leaves room also for architectural aspects with noise absorbing tiles and other possibilities to really make sure that you minimize noise, which is known, as Kathy presented, to be also a risk factor for adverse events during surgery. So finally, let's have a look at the third and one of the main objectives, of course, of ventilation technology in the OR. How does ventilation technology compare with these 3 different concepts: mixing ventilation, laminar airflow, and temperature-controlled airflow, in terms of preventing the risk for surgical site infections based on a high microbial load of the air? So per definition, ultra-clean air is described to be less than 10 colony-forming units per actually this should read, sorry for the typo, cubic meter of air. So this is what you ultimately want to achieve, and there's 3 different principles. The temperature-controlled airflow principle I already explained to you. The turbine mixing ventilation mainly works, on the basis of air changes. That's the key parameter, but it usually doesn't achieve a proper reduction of colony-forming units, even when it comes almost as high as 60 air changes per hour, and it has a high energy consumption. The laminar airflow technology basically maintains a protected zone with this unidirectional flow in the center. The air changes are between almost up to 100, which also creates quite some energy consumption. The required ASHRAE standard is between 20 and 25 air changes. You, however, create a limited ultra-clean zone in the air, and in the periphery you face a lot of challenges, and we have analyzed this by different experiments. One was, of course, with simulation studies by computational fluid dynamics. Here is data from the Royal Institute of Technology in Sweden, Stockholm, and on the left-hand side, you see the temperature-controlled airflow, and on the right-hand side, the unidirectional laminar airflow system. And you know, based on the release through external air showers, you also manage the air in the periphery, and you prevent vortices from developing, which is a critical issue, because usually here at the borders of the protected area, and that's independent of the ventilation system, it's just the workflow setup, you have the instrumentation trays that could get contaminated if you get these huge vertices that actually, you know, bring in contaminated air that has been taken out back into the protected zone by you know, these vortices. And you could even call this almost a bacteria trap if you want. And by this, I guess it is also getting better understandable. And I have some smoke videos also to illustrate this further, that air in the operating theater is a complex issue, because the entire setup of this entire room has to be looked at from a very comprehensive point of view, because it's one consistent thermodynamic system, basically. So based on these aspects, in Europe we see a growing movement away from laminar airflow. There's also been quite some studies on that, because obviously it seems that laminar airflow technology seems to be prone to let's say disturbing factors, so to say, and so that even the WHO has recommended that LAF should not be used to reduce the risk of SSI for patients undergoing total arthroplasty surgery. Of course, this is still a topic that is under discussion, but it also shows that there is a need to really look into the issue of managing airflow in the operating theater more closely. And here you can see these experiments with the smoke, showing how this is actually turning back in. You know, you see that the smoke that has been brought up here, you know, by this vortex flows back into the internal area. And the other aspect is, you know, when you have these kind of laminar airflow systems, you know, that obstacles, because of the high velocity of the air, are basically not clean. They create a let's say a shadow effect, and this traps also the air here, which also is an issue with regards to bacterial contamination. So to show you a little bit about the body convection, you can see here on you can see here, you know, that the smoke that has been brought up is actually, because this air that comes from these air showers is 1.5 Kelvin cooler, and basically gravity brings it down, that the body convection, the heat that the human being produces, is actually broken, and that the air is taken down. And here, what you can see on the right slide in the video in a moment, I just want to point this out to you. We have an OR light that we even put in a horizontal position, which is actually the maximum that would create a shadow underneath, basically. And if you basically now have a look at the video. So basically, when you bring up smoke underneath this OR light, whether it's very low here or closer, you get a full downflow and cleaning of this area, even if you bring it directly underneath the light. And this is because the airflow is a lot more homogeneous with this gravity downflow as compared to this fan induced downflow that you usually get with laminar airflow systems. So to look also at some direct measurements of air contamination with colony-forming units in the air, we have collected clinical measurements during live surgery of more than 700 procedures with different numbers of staff present in the room with various clothing concepts and different surgical procedures. And as you can see here on the left-hand side, the averages were always way below the required 10 colony-forming units per cubic meter of air in the wound area at the operating table, way below 1. The median actually is at 0, and in the periphery it's still only 4. We have recently conducted a measurement at one major US academic center in multiple operating rooms during live spine surgery. And the scale, of course, is a little bit different. So you see in blue again the numbers from the left-hand side, and you see what the measurements turned out in this academic center. And as you can see, the wound area was at 4 colony-forming units, but in the instrumentation tray and in the periphery, it was significantly higher, about 10 times higher than compared to the temperature-controlled airflow operating theaters that we had measured in the past. We also have first clinical data that TCAF implementation also reduces surgical site infection. This is a study that we did in collaboration with some partners in the Ukraine, where we looked at 1,000 consecutive cases of primary total joint arthroplasty before and after installation of temperature-controlled airflow, and we could see a decrease of the surgical site infection rate in this cohort from 3.1 to 1% without changing other aspects of the treatment course. So they were all getting antibiotics, and there were also comparable procedures, and also demographic data was comparable. The postoperative length of stay was also reduced. You may be surprised when you are in the US about the long intra-hospital stay in general, but that's due to how the healthcare delivery and the cultural differences actually require the hospital stay after these procedures in the Ukraine. Yeah, here's some pictures how you can set it up. So it's a very flexible configuration with the temperature-controlled airflow, and currently there's a lot of discussion going on in Europe setting up more rigorous standards on the improvement of the microbial contamination to minimize surgical site infections. So far, the US standards are rather silent on what constitutes an acceptable level of microbial contamination operating rooms. This is something that in Europe is currently a big topic, and we are working also on a European standard that will probably come close to the requirements by the Swedish standard. So here is just one more insight into one of these setups with the temperature-controlled airflow, and I want to summarize with a few key takeaways for you. As Kathy has pointed out, surgical personnel faces significant health hazards from airborne contamination, and including toxic compounds, viral bacteria, and viruses, which require ventilation systems to maintain, proper occupational health setups. Noise is a health hazard for the personnel, as well as a primary cause of medical error. And therefore, of course, this is also an issue that has to be addressed from an occupational safety point of view, but also, of course, from a patient safety point of view, especially as we know that conventional ventilation is the source of noise and thermal discomfort and destruction of surgical personnel. The the data that has been put together so far in various studies has shown that temperature-controlled airflow has been found to create a more comfortable working environment for the surgical staff, but that's not the only aspect. We also know that TCAF is able to really maintain ultra-clean conditions within the entire operating room, and this has been shown to significantly reduce the risk for prosthetic joint infection. And we also have seen in several studies that laminar airflow does really not always maintain the ultra-clean conditions, and this may actually contribute to the incidence of surgical site infections. And therefore, major institutions like the WHO don't really recommend the use for infection-sensitive surgery anymore. Moreover, finally, temperature-controlled airflow exceeds the ASHRAE requirements and is therefore definitely an interesting alternative to the existing other ventilation system concepts. So far from my end, and I guess Kathy will walk you through the continuing education units aspects briefly before we then start our Q&A session.
Thank you, Dr. Bolita. As far as obtaining continuing education units is concerned, as I mentioned, the presentation has been approved for 1.2 contact hours by Terry Goodman and Associates. To earn a certificate, you must have missed no more than 10 minutes of the program, and you must complete an online evaluation. We will be sending your email address to Terry, and you will receive an email within 48 hours with instructions for accessing the evaluation. To get your credit certificate, you need to complete that evaluation and return it by January 31st. If you don't receive an email, you can contact Terry at the email address below or at that phone number. You might want to record that. But that's how you obtain your continuing education units. And then if you just want to move to the next slide, we can begin the Q&A. There we go. I know that we have 2 questions. I don't know if they want to be asked live, but 2 have come in through the chat function.
You mentioned that the system has been proven in live surgery. What is the evidence and how was it obtained?
So mainly we used active air sampling units that we place in different positions in an operating theater during live surgery to also suck in air from the immediate area of the wound. There was a pipe used, basically a sterilized pipe that provided the extension to the unit that was collecting, so the active air sampling unit, basically, so that we could really maintain air from these areas. And basically, every 10 minutes, we changed the bacterial plate so that for the entire surgery, we were collecting different plates and then could count the colony forming units, as these active air samplers are standardized for the airflow that goes through, so we know the air volume, and we have also the time, and therefore we can see how many colony forming units per cubic meter of air are there to be registered during the surgical procedure. So basically, as I said, from incision to wound closure, we were sampling air at different spots in the operating theater.
There's another question here. Why hasn't there been more studies relative to the impact on temperature-controlled airflow and surgical site infections?
And that's actually a very good question, but also perhaps not so difficult to answer. The problem is that the endpoint of an infection is therefore hard to measure if you really want to relate it to the causative agent. There's many factors impacting surgical site infections. A lot of the surgical site infections, of course, is prevented by the perioperative antibiotic prophylaxis. So you need really a huge number of patients if you want to look into this, especially when you have very high standards of cleanliness with regards to air in the operating theater and so on. It is not as easy to really set up these studies. It's easier when you basically, especially if you compare it to rather sophisticated ventilation systems that have been established, as this is the case in many operating theaters in Europe and in Germany. It would be interesting to see, especially if I look at the data that we have from this large US academic center, to do some of these studies also with larger cohorts here in the United States to look at this. But it's basically, as I said, it's a significant effort to conduct these studies. You may need multi-center studies. And also the discussion with regards to surgical site infections has basically come up within the last 5 to 10 years more again. Before that, the focus was more on other aspects to be optimized and not so much on the air in the operating theater. But Kathy, perhaps you can also comment on that.
Yeah, I would say that it's the issue of the number of patients to power a study of that nature. But I also think that if you subscribe to the idea that there is a strong correlation between airborne contamination and surgical site infection, which has been proven repeatedly, that you would want to reduce airborne contamination to an irreducible minimum, and that you would want to look at the technology that is best able to achieve that to the closest degree possible. And so maybe, instead of looking at this threshold of evidence being reduction of surgical site infection, that we instead move to looking at evidence of microbial contamination or lack thereof, the ability to maintain ultra clean standards, and use that instead as the standard for operating room ventilation, rather than looking at what could be an unrealistic expectation around studies with regard to surgical site infection.
Yeah, that is the way it's being done in Europe mostly, that many hospitals do a before and after study, and they measure how many bacteria are there in the air before installation and afterwards. And then you usually see this about, depending on what they have before, but possibly a 10-time reduction in the level of airborne contamination. There's another question here regarding that temperature-controlled airflow is new to the US. There is so far only one installation. How well is it received in Europe, is the question.
Well, as you could see, I mean, it is also not an old technology, if you want. Within the past 10 years, this has been introduced to the markets, mainly in the Scandinavian countries, where it started. And actually, that's no wonder, because in terms of infection control, the Scandinavian countries in Europe have always been at the forefront, basically. It's getting more and more traction. We have first installations in Germany and Switzerland now. So the most installations still are in the Scandinavian countries, but also in the Netherlands. So it's getting a lot of traction and ground and a lot of attention. I would say for technology that is out there for now, basically, or has been basically started 10 years ago, I guess it has a significant impact these days. And I personally am surprised about what has happened basically for the past 5 years, where I'm following the technology a lot more closely because of the research that I'm doing on temperature-controlled airflow. So I would say it's getting more and more traction, and it's fairly well received. Of course, there still is some discussion out there, but that's actually the important part. And I guess, with more and more data being able it will get more traction even within the next few years, I'm sure.
Excellent, thank you. I think we are reaching the hour now. We have been spending one very interesting hour together, learning a lot. We are so happy to have been able to have you here listening to us and taking part of the knowledge being shared by Kathy and Clemens. Thank you very much to you attending. Thank you very much to our presenters. And if you're interested to learn more about temperature-controlled airflow, just contact either of us, and you have, of course, lots of information available at the Avidicare website as well. So with those words, I wish you a pleasant continuation of the day and looking forward to working with you towards zero infections. Thank you.
Thank you.
Thanks.